We'll hear from Dr. Colon from UT Southwestern with a paper entitled Effects of Thoracoabdominal Aortic Aneurysm Height Index on Midterm Survival After Fenestrated and Branched Endovascular Aortic Repair.
Thank you for the Society for the opportunity to present. My name is Jesus Porras-Colon. This is our disclosures. Well, as you know, the size criteria for thoracoabdominal aneurysm is not as clear as for infrarenal. The reason is that we don't have as clear evidence for support that. Aortic height index has been widely studied mostly in ascending and root aneurysms. For that reason, recently the American Heart Association guideline include that in patients who are significantly shorter or taller than average, this kind of index helps a lot. And they also point out that nomograms, accounting age, sex, and height, assist to determine the degree at which the diameter deviates from the normal in the general population. Having said that, we developed this project about using the VQI database in patients who underwent endovascular repair for thoracoabdominals, including 3 groups based on aortic height index. And the main goal was using COX and survival models to determine the impact of the aortic height index. And we wanted to set up a AHI cutoff determined by a ROC court. We had 1,275 patients when they went FEVAR for thoracoabdominal repair. Most of them were type 2 thoracos. The differences, the main one was the main aortic diameter in the third group. And also we identified that the third group had worse survival and worse 30-day mortality. As you see here in the Kaplan-Meier, as greater the AHI is, as worse the survival. We saw that also in the death-related, and we determined with the COX analysis that dialysis, COPD, and symptomatic status were related with reduced survival. Also, we did a comparison with the diameter and the aortic height index, finding that the optimal aortic height index for thoracoabdominal repair was less than 3.5. And we determined that in our cohort, only 46% of the patients meet that threshold. And also, we saw that aortic height index was slightly better than diameter alone. This nomogram helps you, individualize the patient decision. As a conclusion, there is a negative association between the aortic height index and the midterm survival after fenestrated endovascular repair for thoracoabdominal repair. And the threshold that we identified in the VQI dataset was more than 3.5. Only 46% of the patients met this threshold. And it seems that aortic height index is a better estimator of mortality than the aortic diameter alone in both men and women. But this obviously needs further research. Thank you so much for the opportunity.
Thank you, Dr. Colon. Certainly interesting results there. I'll ask a couple questions while we wait for the crowd to come up to the microphones. Firstly, I think that a lot of this emphasis on body habitus and height originated from studies in the cardiac literature about BMI and safety for sternotomy and cardiopulmonary bypass-based procedures. And the height, I think, came a lot as you presented, but also from connective tissue disorder patients who are usually have abnormal ratios in that respect. I know that you excluded connective tissue disorder patients here, but if you're assessing this as a large cohort, can you comment on why those patients were excluded?
We exclude those patients because we wanted to assess the general population with the height, and we choose the height because you know that there's some research about with the BMI, and we thought, like reading all the prior literature, that the height was a better estimator than the BMI, and we didn't want to have patients with connective tissue disorders that you can argue that they're gonna be taller and that is gonna affect or be biased. That's why we exclude them.
Thank you. And one other one, now that you have this data from such a large cohort across the country, have you started to approach your patient population differently on presentation in the office? Or do you have plans to do that, or is it still an evolution?
So, like, I gotta tell you, like, the idea to doing this was when we were in clinic with Dr. Trimmerman, he also, a lot of times he asked me, what is the height? What is the height? And then, like, we were reading with Dr. Rahman on this. We also presented last year in the European Society of Vascular Surgery our research only in descending. And we have been using this in patients. It's not for all patients. I think that this is for individualize the decision in patients that maybe are not like in the general population. Like, for example, you see the average of height in the U.S. for a male is 5'9". So what happens, for example, if you have a patient that is like 6'4", and you have a 5.5 centimeter aneurysm, so that maybe could affect your decision. Or the other, like, for example, you have a female that is less than the average. The average of the females in the U.S. is 5'4". So let's say that she is 5, and then let's say that she has a 4.3 aneurysm. So that is why the normogram is really nice, because with the normogram you can assess that the risk and say, well, maybe she needs the repair right now and not wait until 5. Or the other reason, maybe he's tall, he doesn't have a genetic disease, maybe we can wait for his repair. But the goal of this is individualize the decision of the patient. That is the goal.
Great, thank you. Dr. Shuja?
Hi, very fascinating research. Do you really make a case for operating on women at a 5 centimeter AAA if they are of a shorter stature? Because what I get from your data is, even if you repair them, because these are all patients who underwent a successful FBWAR,
yes,
and the overall survival is still different based on the 3 different segments of population. So maybe this is a more representation of their overall cardiovascular health, and that operating on them earlier based on their height doesn't take away the survival gap.
Yeah, that is a fair question. Like, as you know, BQI doesn't give us all the data that we need to determine that, and it's right. It could be related to the cardiac wellness of the patient. But in the other hand, like, as I told you, like, the main goal of this is individualize the patient and have more tools to make the decision, because we are making the decision based on data extrapolated from the infrarenal size with studies that are kind of old. So that is why we're kind of doing this type of research.
All right, thank you. That was an excellent presentation.
Thank you. Appreciate it.